Hello, my name is Shoko Kure, postdoctoral research fellow, Department Pathology at Bethesda Deaconess Medical Center, Harvard Medical School in Boston. Thank you very much for this opportunity today. Here's who I am. I am a pathologist and a physician scientist whose subspecialty is thyroid pathology. Currently, I'm working as a researcher at Dr. Carmelo Nuchel's preclinical thyroid cancer research lab. I would like to thank ThyCa, Bite Me Cancer, American Thyroid Association, and all the donors for the great funding opportunity. I'm currently funded with the Medullary Thyroid Cancer Research. Today's topic is challenges and difficulties in pathological diagnosis of thyroid cancer. So here's the first question. Is there differences in pathological diagnosis of thyroid cancers between countries? The answer is yes. This is an example of papillary thyroid carcinoma, PTC. I think more than 99% of the pathologists around the world agree with this diagnosis. We diagnose PTC with these nuclear features: changes in size and shape, membrane irregularities, including nuclear grooves and pseudo-inclusion, and chromatin characteristics. This is a picture from follicular pattern structure with delicate nuclear features of PTC. When it comes to this tumor, there's been a long debate in diagnosis. For example, different threshold, inter-observer variation, disagreement, international variability, and so on. Benign or malignant observer variation in the delicate nuclear features of non-invasive encapsulated follicular tumor is significant among pathologists, especially between Western and Asian pathologists. Western pathologists often diagnose these tumors as malignant tumors, regardless of invasive growth. However, Asian pathologists often classify the same tumors as benign when non-invasive and malignant tumors when invasive. This table shows the diagnosis of the same case by several pathologists from US and Japan. When pathologists diagnose the same cases, severe observer variations between American and Japanese pathologists exist. As a trend, Western pathologists tend to diagnose as malignant tumors, while Asian pathologists diagnose it as non-malignant tumor. Why this happens? It's hard to tell one single clear explanation for this, but here I'd like to show you an article reviewing the cases which had thyroid procedures between 2004 and 2013 in an academic center in the USA. The incidence of benign follicular adenomas decreased. This resulted in a more than tenfold increase in the ratio between follicular variant PTC and follicular adenomas during the study period. The authors concluded that these results, at least in part, reflect a true increase in the incidence of malignant follicular variant PTC. However, if the increased incidence of follicular variant PTC is due to the lowered threshold of the diagnosis of malignancy, it's possible that some tumors may be overdiagnosed as cancer and may be treated more aggressively than needed. From Canada, the similar trend has been reported. This group reclassified the follicular tumors treated between 1985 and 2003. 35 cases of benign lesions were reclassified into malignant tumors, and they were mainly reclassified into follicular variant PTC. Some articles say the diagnostic variation might be due to the social circumstances because overdiagnosis trend for the uncertain cases has increased in the last 3 decades. Since the last 2 decades, the biological behavior of this encapsulated follicular variant of PTC has been discussed. This table is from one of the publications in 2006. In this article, they assessed the behavior of the encapsulated follicular variant PTC. The patients who had encapsulated carcinomas had a significantly lower rate of extrathyroid extension and lymph node metastasis compared with the patients who had non-encapsulated tumors. Several other studies have also shown that encapsulated follicular variant PTC are associated with an excellent prognosis. Therefore, non-invasive encapsulated follicular variant PTC is indolent. Overdiagnosis of these indolent tumors can cause complications related to treatment, even without any prognostic benefits. In some papers, it is mentioned that a stricter criteria for the diagnosis of encapsulated follicular pattern tumor is needed. So to avoid the overdiagnosis and overtreatment, as you might know already, a borderline tumor has been established in 2016. It's named non-invasive follicular thyroid neoplasm with papillae-like nuclear features, NIFT. Here's our short summary. There is an observed variation in diagnosis of the thyroid cancer between the countries, especially with follicular pattern tumors with delicate nuclear features. This might in part due to the diagnostic criteria. To avoid the overdiagnosis and the overtreatment, non-invasive follicular thyroid neoplasm with papillae-like nuclear features (NIFT) has been established. Next, I would like to review the representative mutations in thyroid tumors. VIRA V600E mutation is the most prevalent mutation in papillary carcinoma. RAS mutation is the most prevalent mutation in the follicular pattern tumors. It is present in both benign and malignant lesions in the thyroid tumors. This means that RAS mutation is not an evidence for malignancy nor worse prognosis. The prevalence of VIRA V600E mutation is reported as high as 50 to 90% in Asian countries, while it is 35 to 60% in Western cohort. In addition, VIRA V600E mutation is associated with high-risk PTC in Western cohort, but this is not the case in Asian countries. Here's another question. Why the discordance of the prevalence of VIRA V600E mutation between the regions in the world happens, and why the VIRA V600E gene is associated with high-risk PTC in Western patients, but not in most Asian patients. The statistics was based on a different diagnostic trend between the Asian and Western pathologists. In other words, Asian pathologists exclude RAS-like tumors, and Western pathologists include these tumors into the PTC. Of course, I cannot deny there's a method variance, but I would like to emphasize on the diagnostic criteria for today's session. As a summary, the VIRA V600E mutation is the most prevalent mutation in PTC. The frequency and its significance differ depending on the cohort. Here, I'd like to show you a case. 56-year-old female patient presented with the left thyroid nodule of 3 centimeters. Fine needle aspiration cytology was performed, and it was diagnosed as benign. The nodule became bigger, and then the patient underwent left lobectomy. This is her left thyroid. The nodule was 3 centimeters, and the tumor is encapsulated with clear demarcation. In the high-power field, the nuclear features are delicate. There are no vascular invasion nor capsular invasion. The final diagnosis was NIFT. This case was diagnosed in Japan. 5 years after the diagnosis, no recurrence has been noted. As a last slide, here I present the prevalence of NIFT. NIFT accounts for 0.8% in Asian countries, while 70% in US cohort. How can we think about this trend? In my opinion, this might in part probably due to the diagnostic criteria. Very soon, 5th edition of the WTO classification will be published. I won't talk much about the latest classification since it will take another hours, but the NIFT has recategorized as low-risk tumors from borderline tumor. Still, in my opinion, we need to pay attention to the observed variation among the world. Your take-home messages. There's an observed variation in diagnosis of the thyroid cancer between the countries, especially with follicular pattern tumor with delicate nuclear features. Depending on the cohort, the significance of the VERA B600E mutation can differ. In the 5th WTO classification, NIFT will be categorized as low-risk tumor. Thank you very much for listening. Please feel free to send me an email, any questions and comments.